Thank you very much for the presentation, and thank you very much for the invitation to be here today at the Congress of the Society. Here we are. Is it showing? Yeah, it's showing up. So risk-adapted management at CLL, this is what I've been asked to cover, and I would like to start by, this is it. So I'll say Assalamu alaikum to all of you. Then I can speak in English or in Italian, that depends, but I think I'll stick to English. So thank you very much. And I'll try to cover how the landscape in CLL has changed in terms, I won't cover everything, but certainly it's become very much an adapted approach. This in terms of differential diagnosis, which is a key point. Today, prognostic stratification of chronic lymphocytic leukemia is largely biologically based, and this is a very important point I will touch upon. This allowed us to understand better why we have an heterogeneous clinical course of CLL, and we can define risk groups that go from the patient having a very indolent clinical course to patients having a more aggressive or even a very aggressive disease. Another important point has been over the years the definition of response to treatment, to an extent that we are considering even minimal residual disease monitoring in CLL, something that would have been totally unthinkable years ago, but as I will try to show you, this is becoming a reality. Treatment has changed dramatically over the years, including allogeneic transplant. Now we are talking again of algorithm of treatment and even non-treatment, so we are adapting based on risk factors. New technologies have allowed to define new genetic abnormalities. And then there's a whole chapter of mechanism-driven therapy. So it's no longer chemoimmunotherapy only, but we have drugs that can target pathways which are very important in chronic lymphocytic leukemia. So I think it's fair to say that risk-adapted management is indeed or should be a reality for the management of CLL today. And I'll give you many examples of this. And the final point with two question marks at the end is, are we thinking of eradicating CLL? So this is quite a revolution, but it's something that is being considered. And at the end, I'll close with this point. So I put the slide is why a reason for tailored approach? Because we've known for many years that we have different patients with CLL clinically and biologically. Different patients. This is a very important point nowadays, when this could be easily not a young patient. This could be today a 70-year-old patient, very active, jogging, maybe in a less warm part of the world or in a different month of the year. But this could be a very energetic 70-year-old which would be eligible even without any complicated scoring system for aggressive treatment, including transplant. But this other patient could have the same age but have a performance status which is obviously, even only by looking at him, very different. So we have different patients. Now we can define them much better, but even this is important. Some patients can go to transplant, some obviously cannot do that. So being a bit less superficial, but going a bit more in detail, prognostic markers based on biology. This has been one of the major changes that we've witnessed over many years in CLL. And I think one of the turning points was this paper published 18 years ago in the New England Journal, when cytogenetics could be revisited by FISH, no longer by conventional cytogenetics. And FISH allowed us to I would say, to obtain two important pieces of information. One is that you can get data in the majority of CLL. In about 80–85% of data, FISH is informative. Second point is that FISH correlates with prognosis based on what you find. And many of these abnormalities or non-abnormalities are still valid today. The first and most important has been the 17p, and that curve in red is a very poor curve, as you can see. It looks like an acute leukemia, not like a chronic disorder like CLL. So we learned that 17p do very poorly. In bracket, I added p53 mutation, because you can have patients who do not have a deletion but have a mutation. But a mutation you can find only by sequencing. So this opens a question that we should probably try to do sequencing too. And I'll show you the guidelines at the end. 11q deletion was also a poor prognostic marker in those days, a bit less when chemoimmunotherapy was further developed, but still the data with 11q are less favorable. And the better prognostic group that holds today is the 13q, which has been refined with other genetic abnormalities, but I don't have time, or normal karyotype. But again, karyotype today can be tested in a more sophisticated way. So these markers are very important, but many others have been developed over the years. I just put them together as an old slide. Many prognostic markers. The question can be, A, should we do them? If the answer is yes, which should we do? Because we can do very many. You can do 49D, you can do ZAP70, immunoglobulin status. When? That means at what time during the course of the disease? At diagnosis, treatment, relapse. All patients. I won't go into detail of this. I'll just say what we think and what the guidelines will show later as a key point for clinical management. So this is really risk adapted. So the bottom line is that the biological parameter today can guide, and I would say should guide, treatment decision. We're talking about treating a patient of FISH for 17p and p53 mutation. So that when we treat a patient should be done. At diagnosis, it's not necessary. The guidelines clearly say that you don't need to test them at diagnosis, but you must test at the time of treatment. First treatment and at retreatment, because the incidence of 17p and p53 can be much higher at relapse. At the time of treatment, it's about 10 to 15%, but at retreatment, at relapse, it can be 20, 30, 35%. So you must repeat. 11q deletion should be tested. And I'm glad to say, because it's also in the guideline, that immunoglobulin status, mutated or mutated, is a very important prognostic marker. And this is a figure showing what I'm talking about, immunoglobulin status. This is from 2 papers that were published in Blood almost 20 years ago, in 99, back-to-back, and simply showing retrospectively that patients having a mutated immunoglobulin profile did significantly better than patients with an unmutated profile. And this has held true over the years. This is a reality until today or maybe yesterday, and I'll show you why. So this is a key point. So the immunoglobulin status should be tested. In the past, we didn't have much to do, but now things are changing. And we've learned why this happens. There's some data that our group produced about 10 years ago, and it showed that the unmutated respond much more to external stimulation, indicating that the B-cell receptor in the unmutated cases compared to the mutated, which are down on the slide, respond much more. So they respond to stimuli, and that is why they proliferate more. The mutated cases do not respond to signal. They are therefore in an anergy state, and that is why they do better. So treatment. The algorithm has certainly changed. In the old days, for many decades, on the left part of the slide over there, you can see that it was a wait-and-watch policy. If we needed to treat, we largely gave chlorambucil, and it was a very conservative approach. Then the scenario changed with the new drugs, and the starting point was fludarabine, then fludarabine with cyclo, then chemoimmunotherapy, mainly with anti-CD20. And then other drugs came on the scene. I put down new drugs. Bendamustine, as you may know, is not a new drug. In fact, it's a very old drug that was developed over 50 years in Eastern Germany. But it wasn't available. In fact, it was poorly known because of politics in those days. After the fall of the Berlin Wall, bendamustine became available and is widely utilized. And then at the bottom line, there is a most important the chapter of the mechanism-driven drugs. Largely given alone, but I added there also in combination. That is where we're developing now. So this, if we correlate treatment, what you've just seen, to definition response, this has changed dramatically over the years. In the older days, it was a conservative approach, chlorambucil, so it was, in a way, a palliative approach. So all we wanted to obtain was a clearance of blood as a primary endpoint. Then with the chemoimmunotherapy, we learned that this approach is much more active and has a much greater debulking activity. and you can therefore clear the blood, and then it was obligatory to go and see the marrow and check if the marrow was clear too. At that point, it became evident that morphology was not enough, and we can use minimal residual disease. You can monitor CLL by flow cytometry, and if flow is negative, you should do molecular biology. Every case has an immunoglobulin gene rearrangement, which can be targeted with a probe per patient, and you can monitor by quantitative PCR the neoplastic clone. Then when the B-cell receptor agonist came on the scene, the scenario changed again, because the B-cell receptor antagonist control the disease. So it's control versus potential eradication. Most patients with ibrutinib and idelalisib don't go into complete hematological remission. So the disease is there. So obviously you don't monitor minimal residual disease. But this is again changing, because the preliminary data from the combination study with the new drugs indicate that many have a very profound debulking and can obtain a state of MRD negativity. So it was palliation, then MRD, then again just control, and now we're going again into MRD. So an approach that is certainly very intensive. So what are the drugs? The mechanism-driven drugs are targeting two pathways in CLL. The B-cell receptor, which I showed you was very important, and we have biological reasons to know that. And the prototype has been the BTK inhibitor ibrutinib, but we have others, acalabrutinib and others too. And the other big chapter is out of PI3 kinase delta inhibitor, prototype idelalisib, but other under investigation. Idelalisib has been less used because there were some complications in some trials, and it was stopped for some period, so we have less data. The other major pathway is out of the BCL2. We've known for very many years that BCL2 is always overexpressed in CLL. So if we can down-modulate BCL2, this obviously would be important in this disease. This was tried in the old days, but was not effective. Then there was a first drug, ABT263, navitoclax, that was attempted, but it was toxic and was stopped. Then a new generation was developed, ABT199, which is venetoclax, very active and approved. So what is the scenario for the drugs? We had an interesting story in Europe that EMA, the agency in Europe, approved in 2014 ibrutinib and idelalisib plus rituximab for relapsed CLL, but EMA, the agency, not the companies, when they applied for approval, extended indication. And extension was to 17p53 mutated patients. And why was this done? This was done because this was a primary unmet need. Patients with 17p or p53 did so poorly that it was felt ethically right to try to offer these innovative drugs. This did not happen with FDA, so it was something that we had in Europe. Very important. Because these are the data. If you treat p53 disrupted patients with chemoimmunotherapy, the data are very poor. You see this in the two panels. The patient 17p or p53 doing very poorly. On the right panel, it's the blue lines. These are patients with a p53 mutation doing poorly. If they're wild type, they respond much better to chemotherapy or chemoimmunotherapy. So having new drugs treating a p53 mutated patient, if you identify it, is probably not correct. So this is risk adapted. We should identify, and if the new drugs are available, they should be utilized for these patients. So 17p and p53 are really a key point. To an extent that studies have been done, this is a study that we did in Italy, by deep sequencing. You can go down to identify minute subclones, and the minute p53 subclone appears to have a similarly negative prognostic impact. So we might be extending further the indication of the new drugs. Not approved yet, but it might happen. So this is for p53. The new drugs, have they really changed the prognosis? Well, it is very clear that both ibrutinib and idelalisib are certainly very active with patients having a 17p mutation or p53 disruption. But over time, the data are less good, so we haven't completely solved the problem. If you look on the left panel with ibrutinib, you can see very good, this is a long-term follow-up with ibrutinib, and the red line on the top shows patients that do not have a 17p and do not have 11q, and have a progression-free survival at 30 months of 89%. So this is extremely good. If you carry an 11q, it's a bit lower, it's a blue line, and if you go and see the 17p, this is significantly lower. At the follow-up of 30 months, it's 46%, so it's half the response if you don't have a genetic abnormality. So again, genetics is guiding. So the responses are good, but they're not optimal. So we have to improve for these patients. What about immunoglobulin status? Not that dissimilar. This is the other major unmet need. The unmutated cases do poorly. You see it here. You see the purple and the yellow line. These are patients treated with FCR, bendamustine rituximab, and the third line is FC, unmutated. The top line are the patients who are mutated. So significantly lower response to chemotherapy or chemoimmunotherapy if you're unmutated. So this is a second risk-defined group and an unmet need. So is this scenario changing? The answer looks to be exactly the case. These are data, long-term data, with ibrutinib, and you see it on the title, ibrutinib significantly improves progression-free survival in patients regardless of the immunoglobulin status. You see the curves are superimposable. On the left panel, it's refractory or relapsed refractory CLL. On the right panel, frontline treatment. And there's no difference if you're mutated or unmutated. So if you go back to the curve, you see the major difference. So chemotherapy or chemoimmune are not adequate. The new drugs are changing the scenario. And if you see it in red, there's no difference in progression-free survival at 3 years between mutated and unmutated, 66 versus 63. This is for relapsed patients. So this is a very important risk-adapted strategy. Going forward, recently, 2 years ago, ibrutinib has been approved frontline for all CLL patients, irrespective of the biology. So this is not risk-adapted. Based on data of large randomized studies, it was approved by FDA and EMA. So this opens, and I understand you have ibrutinib available here too. This opens a very challenging issue, which I've put here. What we feel in many parts of the world, that this can be a major challenge in the sense that does this mean that all CLL patients, irrespective of age and biology, will undergo a B-cell receptor antagonist, which now is ibrutinib, it's the only one approved, as frontline treatment? This is a key point, but has very many implications. Is it doable, feasible, realistic, cost-effective, and all these practical problems? So I'll try to convince you that based on biology, we can identify some patients who may be spared frontline ibrutinib. So these are data from an Italian retrospective study that we conducted and published a couple of years ago. So this is on over 400 patients with CLL treated frontline with FCR. And you can see the blue line showing very clearly that there's a subgroup of patients who are doing extremely well. That's projected years ahead, and there is a plateau, and these patients appear to be cured, and many are MRD negative. So which are these patients? These patients are patients who have a mutated profile in immunoglobulins and do not carry a 17p deletion or a 11q abnormality. So a good biological profile. This is important because these patients seem to live like the normal population. So these patients can benefit from a short-term, defined time of chemoimmunotherapy. This has been shown also by the MD Anderson, only based on immunoglobulin status, and by the German group retrospectively analyzing the CLL-8, which was a randomized study comparing FC-FCR. So mutated do significantly better. Is this true only with fludarabine cyclo? Because this is very important. I forgot to say many of the patients are MRD negative, and MRD negativity obviously is important to an extent that if you can get a status of MRD negativity, could also mean that you stop treatment and you might be cured. Is FC the only backbone of chemo? Well, this is a paper recently published in Leukemia from a green study that incorporates second-generation anti-CD20, which is GA101 or binotuzumab, with bendamustine, so less aggressive chemo. only one piece of information in red. You can see that a proportion of patients becomes MRD negative. In the marrow, 28%. And if you look at the biology, again, these patients are mostly mutated and they do not have 17p or p53. So again, biology is defining a subgroup of patients susceptible to chemoimmunotherapy. The other question would be, will chlorambucil be enough? In the CLL 11 trial, it was chlorambucil with rituximab or GA101. The important piece of information here was, you see it here, that 20% of patients with GA101 or obinutuzumab became MRD negative in the marrow by molecular analysis. The limit of the study is that we don't know which patients. So we would like to know in advance before treating rather than after. So this, unfortunately, we still don't know. So tying this together, it is clear that these observations indicate that the proportion of patients with CLL can witness a very profound response following a short course of chemotherapy, even mild chemotherapy, not only FC, Benda and even chlorambucil.
2 minutes.
These patients appear to have a specific biological profile, at least for FC and bendamustine. And many of these patients become MRD negative. So then venetoclax came on the scene, very active drug, very different mechanism of action, and has a profound debulking activity. This is data from the publication in New England, and these are relapsed refractory patients, had many lines of treatment, and you can see that certainly the data look promising with a good response. This is monotherapy, only venetoclax. 17p on the second panel do well, but less well if they don't have a 17p mutation. Or deletion. And complete responders, the panel below, do better than the partial responders. So very active drug, which led to the approval on the two sides of the Atlantic for patients obviously with CLL with a 17p deletion who had been treated with one line of treatment. Then rituximab was added to venetoclax, and again this has been published, and the addition of rituximab increased significantly the rate of complete response of MRD negativity, going from 20% to 51%. This is significantly higher. And this, therefore, has led to a further change of the approval of venetoclax, and this happened only a couple of months ago at the FDA level, and FDA has granted a standard approval to venetoclax for the treatment of CLL irrespective of the biology, so 17p or 17p negative after one line of treatment. And also with rituximab. This is based on a large phase 3 randomized study, the Murano study recently published, again in New England, showing that for relapsed patient, venetoclax rituximab is significantly more active than bendamustine rituximab. So going towards the end, if we tie together the topic of risk adapted, but the risk adapted means that we have to study patients, and I'm glad to show you this very recent publication. It is an update of the International CLL Working Group guidelines, and I've taken the biological part. This is what is recommended as a published guideline for the management of CLL. It's divided in general practice or real life compared to clinical trials. And it says in line of what we discussed that FISH has to be done, always. We skipped the second line. P53 should definitely be done always. Particularly if a patient is 17p negative, you should try to sequence. Whether this is doable, that's in the final slide. Immunoglobulin status, equally, it should be done. Conventional karyotype is developing very interesting, but it's not yet indicated. So what we need is FISH and sequencing for P53 and immunological status. I mentioned combination studies. These are ongoing studies, so we don't have firm data, but the first data already presented, this is from ASCO this year, show you that combining ibrutinib and venetoclax frontline, you can get a high proportion of patients becoming MRD negative in the blood and in the marrow. So this is opening a new frontier. Chemo-free, 2 biological agents, very active, and apparently a very high proportion of MRD negativity. Phase 3 studies are underway. One is in the UK, And this is ibrutinib plus venetoclax versus ibrutinib monotherapy versus FCR. And the other one is a very large German study, started a couple of years ago, CLL 13 trial, frontline again. There's ibrutinib plus venetoclax plus obinutuzumab versus venetoclax rituximab versus venetoclax obinutuzumab versus FCR. It'll take 2 to 3 to 4 years to have final data, but these are clearly studies with largely comparing with chemo to see the profound effect of the combination of the new drugs. I just took this algorithm of treatment published by Tom Kipps just to give you an idea here too that the biology is incorporated. You see the 2 arrows. If you need to treat a patient, you should test for deletion 17p or mutation. If they're positive, you go to BTK inhibitors, venetoclax, you have a wide array. But you have to test them because you have to go to targeted treatment. If they're negative, then the mutation status becomes a key point, and based on the mutate or unmutate, you can decide for chemoimmunotherapy or for the new drugs. So I'm concluding. So here are some final thoughts. It is very clear that it is always more a biologically driven management of CLL, which I remind ourselves that for us, CLL is the most frequent leukemia in adults, so it's not a rare disease. We need an integrated clinical biological workup for an optimal management of patients. This is an important point. And in addition to what I've shown you, this will come soon. This is complex karyotype. I added a slide now this morning, but I think it's relevant to say where we're going. By using stimulators, we can get mitosis, and the complex karyotype may further refine our risk-adapted management of CLL. Then going back, algorithm treatment or the reality. Now that ibrutinib is frontline, the decision is, will it be ibrutinib or will it be chemoimmuno? I think that based on the biology, we have an idea of what should be better for patients. So again, this is risk-adapted if we can apply biology. But we need a network of laboratories. This is a key point. I don't think every center can do everything. This is unrealistic. We have a network in Italy, and laboratories are identified, certified, and they do certain tests. Clearly, there are different realities in different countries and regions, and traveling around, you see the problems that we are witnessing. There are issues of availability of tests, not only of drugs, even of tests. Sequencing is not widely diffused, as you know. Accessibility, again, a big problem, and sustainability. Who's covering the cost of everything? This is becoming worldwide a very important point. At a national level or a hospital level or university, we have budgets. So these are practical issues. That's why I think risk-adapted can probably allow us to optimize resources. Growing role of MRD, this is something that is certainly going to be the key point for the future, and this is very important. So this opens to what I had mentioned beginning. Are we moving towards an era of disease eradication? This is possibly happening, and this will then open the issue, can we cure CLL? Because you can eradicate, that is a question. But I have one more slide, which is this one here. Just remind ourselves that CLL is an heterogeneous disease. You can have stable disease. You can live with CLL and die with CLL, but not of CLL, never treated. You can have a slowly progressive disease. So do we need to eradicate a slowly progressive disease? That is a question that I pose to myself and to everybody. If a patient is 75, mild treatment can contain, you may not need to eradicate. Rapidly progressive is very different. There, I think we need to eradicate with whatever we have, which would have been transplant in the past, and now it's the new drugs, and it will be the combination that will come soon. And I've finished, and I have a second word, which you know very well. So thank you very much. Shukran.